Good afternoon, everybody, and welcome to another NOLEX Infection Prevention Control Conference series of webinars. Today, we're going to be looking at recognizing Lyme disease. And with us, we have Arlene Braley and Dr. Anne Cruikshank. Arlene, could I ask you to introduce yourself, please? Your mic's on mute, Arlene.
Thanks very much, Rob. Good afternoon, everyone. Lovely to be here with you. I'm Arlene Braley. As Rob said, I'm a pharmacist by background, and I'm also one of the founder trustees of this registered charity called Lyme Resource Centre.
And Anne.
Hi, I'm Anne Cruikshank. I retired from general practice a year ago. I've had a long-standing interest in Lyme disease. I was the RCGP clinical champion, and I now volunteer with the Lyme Resource Centre, focusing on developing education for health professionals.
Thank you. Just to let you know that you can submit questions through the chat as we go, and we'll endeavour to answer some of those towards the end. And I will now hand you over to Anne and Arlene to continue the presentation. Thank you.
So welcome everyone to something perhaps a little different for you today, recognising Lyme disease, and we've called it the new great imitator, and that will become clear later on why we use that title. Just to tell you a little about our own background as a charity, Anne and I both have health professional background, but we're involved in this charity because it's got a mission to do two things. One is about helping the public understand more about ticks, tick bite prevention, and importantly, recognising the early signs of Lyme disease. And our second main thread is to work with health professionals like yourselves to share the knowledge that we have and enhance what you already know about Lyme disease and some of the things that we have learned ourselves along the way through different means. More of that later. So as a charity, we do a lot of work in the outdoor space because it's all about enjoying our wonderful outdoors. Aren't we very fortunate across the UK to have beautiful spaces of outdoors to enjoy? And sometimes that's in our garden, walking. Sometimes it's doing things like fishing, hill climbing, whatever it might be. But there's space here for us all to know how to stay safe against ticks and tick bites and why it matters. So what are we hoping to cover with you today? Well, we've got quite a list here, and it will be a bit of a whistle-stop tour. We hope there'll be something for everyone. Not everything will be relevant to every sector of practice, but we know there are parts that affect all areas of working within the health sector. So we're going to cover a bit about ticks and tick bite prevention. We're importantly going to cover the signs and symptoms of early Lyme disease. And then we'll look into some of those diseases in areas where the signs can be mimicked, and it's actually quite difficult and quite complex to work out what is the cause here. So we hope to give you lots of information that will help you to think more carefully through, could it possibly be Lyme disease? We'll then talk a wee bit from a primary care perspective about how do you differentiate an erythema migrans rash, which is diagnostic of Lyme disease, against other insect bites and rashes. And then we'll think about some of the signs to be aware of in children, for those of you who are working with children or who see children in your practice. And then, of course, importantly, where's the evidence base around all of this? Well, there is a NICE guideline, and it's really important that we highlight that for you so you know where to go for that information and that evidence base of treatment protocols, etc. And finally, as a charity, one of our main routes of information is to make our website as full and as easy to navigate as possible for you to get the information you need for yourselves and for your patients. So that's where we're going today. And the question really is, why do you need a working knowledge of all this? Why does it matter? Well, I would like to suggest to you, for your patients, it is really important. It's important for those early stages, the early stage of diagnosis, where it's perhaps a summer flu, or it might be an unusual rash, or it might be patients that have been very well in the past and suddenly they come in with all sorts of unusual, puzzling, unconfirmed symptoms, and you just don't know what's wrong with that person. It's also important for you, we would like to suggest, on a personal level, for you to stay safe while you're enjoying the great outdoors and any of the outdoor activities that you and your family enjoy. And in terms of the wider groups that you mix with, do you know, some of you or some of your friends or family may be scout leaders or guide leaders, might be involved in Duke of Edinburgh expeditions, or your children may be going on some of those this summer as helpers or perhaps as participants. And so as the tick populations are rising, and we'll tell you more about that, so are the cases of Lyme disease. So let's make sure this is not just about professional knowledge, it's actually personal and has application to you and your families as well. Why does it matter? Well, because a missed diagnosis of Lyme disease or misdiagnosis or inappropriate treatment, any of these can lead to long-term and debilitating, life-altering outcomes, and it can be a very difficult road back to health. Why do I say that? Well, this is where I share a wee bit of my own personal story with you, because my son went on one of those outdoor expeditions in his teenage years. He went on quite a few, actually. And on one of those, he was bitten by a tick that we know of, and he removed it correctly. But what I'm about to tell you is, if only I had known back then, those years ago, what I know now, things would have turned out very differently. What we found was poor knowledge leads to very poor outcomes. So this was my son in his middle teens. He loved all these outdoors. And 2 years after that tick bite, he was just getting more and more tired, more and more lazy. And then about 3 years afterwards, he went off to university and found after a few weeks, he couldn't even get out of bed. Nobody knew what was wrong. He had all sorts of symptoms going on. And at that stage, he was diagnosed with depression. It didn't sit right with me. I just knew something wasn't right. And when we put the picture together, we realised that actually there were things that we had missed here. He actually got to the stage where we had worked out that this was probably Lyme disease because of the host of symptoms. So by then we sent off for a test, the NHS test. It came back negative. And back there, I just thought, oh, well, if it's not Lyme disease, what is it? I didn't realise then that the testing can be very difficult and it's not always a reliable outcome. So he ended up being sent down the route of psychiatry for 3 years. And meanwhile, the infections just continued to rage round his body. At that stage, he never even managed his first year of university. He tried twice, didn't manage it, and he actually steadily got worse and worse and worse and more ill. And he ended up being in bed for almost 8 years, where we became his carers. What did that mean? Well, there was so many things suggested, chronic fatigue. It was something else that was happening. The worst of it for us was he had so many conflicting symptoms, and I knew deep down this was Lyme disease. He had eye problems, floaters in his eyes. He had headaches back and front. He had tremors in his limbs. He had pains up the soles of his feet. He had lots of tremors in his muscles. His gut was affected. He had brain fog. He had fatigue. He had so many symptoms that he just couldn't cope with daily life. And over that period of 8 years, there were so many losses, not just for him, but also for us as a family. Friendships were lost. His education stopped. He was unable to hold down a job because he'd become bedbound. He had no energy. He missed all the birthday celebrations of the family. He didn't make any Christmas days. He was bedbound. And he lost his independence, which was the worst thing for a young man in his 20s. And so one of the reasons I'm personally involved in the mission of our charity is because if only I had known then what I know now, we could probably have prevented a lot of the suffering here. And so we're very keen for you to know what we know as well, and to be able to spot these things early when treatment can lead to very positive outcomes. So on that note, what we want to say today is please keep Lyme disease on your radar. Whatever area of practice you're in, be it primary care, be it secondary care, be it in a GP medical practice, or if you're in a community pharmacy, or you're nursing or physio clinics, you're going to see some patients that will have some puzzling symptoms. And we would say to you, keep Lyme disease on your radar. Could it be, is what we would say to you. Now, at this point, I'm going to introduce you to my colleague, Anne, who's, as she said, a retired GP in Oxfordshire. Anne led the RCGP Spotlight project on Lyme disease back in 2018, and she still continues to do a lot of work with us. And she is the person that you want to hear from on what is Lyme disease and leading you up to that point. And we encourage you to put your questions in the chat box, and Rob will be able to ask us those at the end of the session. Okay, Anne, over to you.
Thank you, Arlene. Okay, I think I'm seeing the chat box here, which I was hoping not to, but still. Hi, so yes, I'm a GP with a long-standing interest in Lyme disease. And what I really want to cover today is how it presents, how you might be able to diagnose it, and what treatment options are available, and what the long-term scientific uncertainties still are. So basically, it's an infection. It's caused by the bacteria Borrelia burgdorferi, transmitted by an infected tick, and the most common tick-borne disease in Europe and North America. So there are multiple genus species, and that causes different presentations. So in the USA, Lyme arthritis and cardiac symptoms are more common, whereas in Europe and Asia, it's more likely to be neurological or skin presentations. And we know the bacteria can spread very quickly around the body, attracted to a range of tissues, and it can hide from and disrupt the immune system. This isn't important to you in detail, except to show that it's at least 100 years, this correlation between some sort of neurological symptoms and Lyme disease has been apparent. But the name itself comes from Old Lyme in Connecticut in the USA, where in 1975, a large number of children were suddenly being diagnosed with juvenile rheumatoid arthritis. And it was actually the parents themselves that led public health officials to investigate this, subsequently found to be due to a tick bite, initially thought to be a virus, then found to be due to this bacteria. First reported in England and Wales in the 1980s, and it's been described as the new great imitator because it mimics so many other conditions. And the comparison here is syphilis, which, as most of you hopefully know, that is another spirochete, which has primary, secondary, tertiary stages. So incidence is difficult really to know worldwide, because there's no standardized way to collect data. In the USA, there's probably nearly 500,000 cases a year. France, 50,000, Germany, at least 50, 60,000. And in the UK, it's been fairly long-standing that the UKHSA has suggested there are about 2,000 to 3,000 total cases a year. It's not notifiable in the UK, which it is in many other countries. And now with the change with the NICE Guideline, it's quite clear that if somebody has an EM rash, they don't need a blood test. So we have this range of lab-confirmed cases and clinically confirmed cases. Recently, the UKHSA put out a report that some of you might have seen suggesting 1,168 acute lab-confirmed cases. Well, that doesn't sound very much and doesn't sound like much to worry about. But what they didn't mention was 727 reported as long-standing Lyme cases. Now, that could mean late Lyme, it could mean undiagnosed Lyme. I'll come back to that testing later. But we know that clinically confirmed cases are not being counted at the moment, and there's some research going on into that. But in Scotland, some research on general practice did suggest up in the Highlands at least 5 times as many GP diagnosed cases as clinically confirmed, as lab confirmed cases. So prevalence in blood donors, so in other words, a positive test in a patient who's apparently well enough to give blood, and there could be various reasons for that, 4.2% up to 8.6% in the Highlands, and in the UK, recent research, 0.49%. But that still adds up to 200,000 adults at least who've been bitten. Whether or not they've been diagnosed, whether or not they've become ill, it doesn't really tie in with that 2,000 to 3,000 total cases. So looking at ticks themselves, they are tiny, potentially. They're in rural and urban areas, and they're carried on birds and small mammals as well as deer. And this is where the confusion potentially lies, because obviously birds and small mammals get into anywhere, gardens, parks. You don't necessarily need to have seen deer running around. And in fact, deer aren't usually aren't really the reservoir for the infection. It's the small mammals and birds. So tick surveillance projects have shown high incidence of ticks up in Scotland, in the south of England, in Norfolk, and the UKHSA is carrying out a tick surveillance program, but that involves people needing to send in ticks. So I'm sure a lot of people don't actually necessarily bother to do that. The fact that there are blank areas on this doesn't mean there's no infection, no ticks there. It just means that they haven't been sent in from there. But you can see a high incidence in south of England. Scotland really probably hasn't been sending this information into UKHSA. So ticks are tiny, size of a poppy seed, and their bites are painless. They inject local anaesthetic, so they'd easily go unnoticed. And they carried as well as Lyme, they may carry other pathogens. And the infection rate can vary up to maybe at least 16%, even higher maybe in some areas. Children probably more likely to be bitten above the waist. And they tend to just not necessarily attach at the first place they touch the skin, but they'll do something called questing and move around and might find just a moist protected area where they're not seen. They can attach for days. There's no proven minimum time for how long they need to be attached. And remember that the tick that might have been seen quite early might not be the one that stayed attached for longer. Also, if it's removed traumatically, you may increase the risk of infection. And don't assume that a tick has to look like this large grape-sized one in the image here. Small nymph ticks will probably remain tiny and not engorge, even if they've passed on infection. So prevention is better than cure. Obviously covering up, wearing lighter clothes, using insect repellent, and carrying a tick removal tool. And doing tick checks if you're outdoors for longer periods, or whilst camping, or after expeditions, or after being outside. People often check their pets, they forget about their children. And when we have done some research in our LRC Lyme disease experience survey, more than half of people had no idea about the need to protect from ticks or the early signs of Lyme. And the importance there is that the signs can be so mild that being aware of them will at least enable a patient to get to see a doctor or look to see a doctor sooner than just ignoring the mild symptoms. So removing a tick, this is always a question. Do you twist? Do you not twist? Tick twisters are for twisting. The idea is, and we'll show you a video in a moment, tick cards and tick tweezers, you just lift and pull up. What you mustn't do is squish the body of the tick. You also mustn't cover them with oil or gels or burn them off with cigarettes, as all these things increase the risk of transmission. Now, I'm hoping that this will work. So we've been working with the Tick Twister company because it seems that tick twisters are available across Europe in pharmacies and yet rarely available easily here, except maybe online. There is a link on our website for you to buy these, and we've been working with organisations such as DOV to encourage that children out on trips or families, that they are equipped with tick twisters. No point waiting for 3 days when they get back from the trip to start taking the ticks off at that point. So it is something to be aware of. Move on. Hang on. Okay, so Lyme disease. has different stages, a bit like syphilis, as I mentioned earlier. So early localized, early disseminated, and then late disseminated. This basically occurs over weeks, months, even years, and there's no specific cutoff, but probably late Lyme is from about 6 months onwards. 6 months after having been bitten and maybe not diagnosed prior to that. There's also this issue of persistent symptoms following antibiotic treatment, which affects at least 10 to 20% of cases where they don't recover after standard treatment. And this has different names: post-treatment Lyme disease, chronic Lyme, long-haul Lyme. But this is not the same as late undiagnosed. This is patients who've had some treatment but not recovered. So early symptoms include the erythema migrans rash, plus or minus flu-like symptoms, which are a bit vague. There's maybe a fever, often neck ache, headache, other aches and pains, but no, not usually any respiratory symptoms. And obviously, if you get an EM rash that looks like that, a bullseye, you're going to be diagnosed and treated, and that should be pretty straightforward. But if people aren't thinking about it, if it doesn't look like that, or maybe they just get diagnosed with summer flu, then that early chance to treat gets missed. So the EM rash usually occurs 3 to 30 days after the tick bite, absent in 30% or more, and it's an expanding red rash. Probably only half of the rashes are actually a bullseye, and it's usually painless. It's not hot, usually not itchy. Sometimes it may be, and it may be very atypical, multiple sites, different shapes, and it's very easy to misdiagnose this as an insect bite, a ringworm, an allergic reaction. And we're very focused there with this issue now of pharmacy first, where patients are seeing a pharmacist with a rash that may look just like any other insect bite. Or maybe they've sent in a photo to the GP, and again, this will be an issue of the photo being difficult to diagnose or needing a much more detailed history. And remember, if the rash has gone away, that doesn't mean the infection has resolved. They do need treating according to NICE Guideline. There's a couple of rashes from the NICE Guideline. Some more here. You can see there can be multiple as they start to spread around the body. This one in the top right corner was a patient who actually contacted the charity when pharmacy first started, and the pharmacist felt that this wasn't an EM rash because it wasn't a full circle. Fortunately, she contacted the charity and got treatment. This here, you can see how difficult that might be just on a photograph. D and E look like if the patient was in a lot of pain, if that was hot and red and swollen, you would assume it was a really severe cellulitis, whereas in fact, they were EM rashes. The top left number A was in fact just a local small infected follicle, but you can see this difficult to differentiate. And if you look at B, in the very center of those eyelid, you can just see a tiny tick attached near the eyelid, near the eyelashes. It'd be so easy to miss. On darker skin, again, you've got another problem with the coloring. Easy to miss the tick bite and easy to miss the rash. Another one there. Borrelia lymphocytoma is another skin condition which might affect the ears, nipples, scrotum, lips, and you can see that variation there with the EM rashes and the lymphocytoma. Another skin condition in late undiagnosed Lyme is acrodermatitis chronic atropicans, which is on the hand there. So early disseminated Lyme, this is when patients are coming in, they may or may not have had a rash, but they might have fluid symptoms, they've got palpitations, chest pains maybe, might be feeling short of breath, might have a facial palsy, which can occur in early or late Lyme. And they might just feeling like they can't concentrate, they don't know what's wrong, they've got unexplained pains. And this could be days or weeks after they got infected and they never mentioned a tick bite, or maybe didn't notice a tick bite. So again, a history is important when people are coming in with this strange array of symptoms. And as this progresses, it can affect literally every system in the body, but again, it's coming and going and fluctuating and migrating. And this is when patients get told they must be anxious or they're depressed. And of course, they're becoming anxious because nobody knows what's wrong with them. Plus, the inflammation in the brain in itself causes anxiety. And again, facial palsy is a big issue. Musculoskeletal symptoms, the cardiac symptoms, there is a significant risk there of arrhythmias and even cardiac arrest. And psychiatric symptoms, some patients may get a range of symptoms, sometimes psychiatric may be the main issue. Pediatric Lyme disease might be very difficult to illicit. The children themselves may not be able to explain what's wrong with them. Teenagers might suddenly develop behavioral issues, deterioration in school performance, perfectly fit during the summer when they did their Duke of Edinburgh, and now September they won't get out of bed. They haven't just become a stroppy teenager necessarily. There could be something else going on here. Some research done in Southampton has highlighted this correlation between Lyme disease and facial nerve palsy, and the advice is that Lyme disease occurring in children who've been in or visited endemic areas should be assumed, facial palsy should be assumed to be Lyme disease until proven otherwise. The challenge here is that if it's early Lyme, the test will be negative. So unless you found some other cause, you can't disprove Lyme disease. So far better to continue the treatment rather than stop it just because the test was negative. And the new great imitator, and this is where it gets complicated. You've suddenly got a patient seeing multiple specialists, receiving multiple diagnoses, and nothing is quite holding together and making any sense. And again, they might be coming and going, migrating, fluctuating. And sometimes really very significant issues, such as being diagnosed with Parkinson's or motor neuron disease, dementia, even when in fact what they've got is Lyme. And a number of patients find themselves being diagnosed with functional neurological disorder because no one's actually thought of testing for Lyme, or even if the test was positive, we've seen quite a few cases where it gets dismissed. And these are the kind of cases that the conditions or diagnoses that many patients said they received before being diagnosed with Lyme. Testing is not required if you have the EM rash, and it is unreliable, especially in early disease, but potentially at all stages. And the guideline, NICE guideline, does say it doesn't exclude, a negative test does not exclude the diagnosis. And if you compare this, thinking about syphilis and Lyme disease, syphilis has a highly accurate test, a test of cure, and an evidence-based treatment. And if latent syphilis is suspected, a positive test with no symptoms, patients will still get treated. Whereas Lyme disease has a variable accuracy in the test, no test of cure. There's uncertainty over the effectiveness of treatment protocols. And if patients tested positive, they may not necessarily be treated. So testing involves a two-tier immune-based test. It's a simple blood test. When patients often report that the GP wasn't sure how to do the test, it's a simple test. What you're looking for is the name Borrelia. It won't say Lyme disease, it'll say Borrelia. You send it to your local lab. The ELISA will be done at the local lab and comes back very quickly. If it's negative, if it's positive or equivocal, then it will be sent on to Porton Down or Regmore Hospital. If a patient has been ill for more than 12 weeks, you should actually specifically ask that the full testing is done, and you need to actually speak to someone to make sure that happens. This is just part of the form that you would use. You can download that easily, just Google Lyme disease request form, and the lab do want as much clinical information as possible, and this can work as a good prompt to make sure you're asked about various conditions. They do need as much clinical information as possible to analyze the results. And this is how it may come back. You might get from Ripple itself a whole list of the various immunoblot results, but local labs often summarize the testing. And if you look at this here, what you can see is that this test on the right, patient B, was found to be IgG positive, IgM negative. Now, if a patient is ill and they've never been treated before, that is not past infection because it's a bacteria. It needs to be treated. In this case, the patient was refused treatment because there was no tick bite history and no EM rash. The patient got sicker and sicker until a second test showed even stronger immunoblot bands and was then treated but has never actually recovered. So this is important to know. This does not necessarily show past infection if they haven't had treatment, but it may be that even after treatment, if a patient's completely well again, a test may never go back to completely negative. So the NICE guideline, when it came out in 2018, a lot of people still don't seem to be very aware of it. What it basically says is diagnose and treat without testing if there's an EM rash. Don't rule out Lyme if the test is negative. and there's a high clinical suspicion, the testing is part of the supportive investigations. If it also says if the test was negative within the first 4 weeks, then repeat after 4 to 6 weeks. But on the other hand, you don't want to be, if there's any chance this is Lyme, it's far better to get on and treat, because otherwise it's going to become harder to treat as the weeks go by. But it is important to be aware here that if you give antibiotics early in the disease, the patient may never seroconvert. So you never get an actual final diagnosis, but response to antibiotics may in itself be the diagnosis. So prompt antibiotic treatment is really key to have a chance of complete recovery. Doses are much higher and longer duration than other conditions, and you should start treating based on clinical suspicion if that seems appropriate. If necessary, after the first course, if they've got ongoing symptoms, give a further 3 weeks of a different antibiotics. Watch out for the Herxheimer reaction, which is usually an exacerbation of the ongoing symptoms due to bacterial die-off, and there's no actual indication for prophylactic treatment, but there might be cases where you would do that. Maybe if they had multiple tick bites, maybe if someone was about to go have chemotherapy, something like that, and they were there was a potential that this was Lyme, it'd be worth considering. But many people still develop ongoing symptoms. So basically, in summary, the rash is diagnostic, treat on clinical suspicion, give a second course if necessary, but also be aware that this guideline has a very poor evidence base, which the Guideline Committee themselves admit, and they feel more research is needed. Treatment, you're not going to remember, you probably need to look this up on CKS or the NICE guideline at the time, but doxycycline 100 milligrams BD for 21 days is standard for adults, unless there's another indication to use amoxicillin, such as pregnancy, or azithromycin. Cardiac symptoms or CNS symptoms might need IV antibiotics. And in children, again, doxycycline from age 9, and if you're under 9, amoxicillin first line. And if you see that's a really high dosage, that would mean that 30 milligrams per kilogram for a 33 kilo child would be on a gram TDS for 21 days. This is quite a good infographic, which you can actually download and even put up in your surgery or pharmacy if you felt that was helpful. We do actually encourage pharmacists to check dosages, because we are aware that incorrect prescribing does occur in both primary and secondary care. So persistent symptoms, for a long time this has been dismissed as nonsense. Chronic Lyme disease doesn't exist. Patients just think they're ill when they're not. But this is research from Johns Hopkins showing a very clear pattern of symptoms. The cause is unknown, is the issue. It might be ongoing infection, it might be inflammation, it may be other infections. It could be an autoimmune triggered response at this stage. But the possibility of ongoing infection is not excluded, and there is certainly evidence that Lyme disease, the bacteria can persist beyond standard treatments. And this on the right is the outcome we had from our patient survey with almost identical symptoms. And this is what you see. A lot of patients, either they've never been diagnosed or they were treated but didn't recover. This fatigue, this pain, this anxiety, memory problems, nerve pain, just unable to function. There have been some retreatment trials which have all been suggested that they showed that there's no evidence that antibiotic treatment, further treatment will work, but these have been questioned. The conclusions from these have been challenged. So key points: it's complex, testing isn't always reliable, and early and adequate treatment is the best chance of recovery. And I think if patients come to you, they've probably by then done quite a lot of research. Lyme Resource Centre has a lot of information on the website, so do some of the others, such as Lyme Disease UK. And patients will come to you with information which you should think carefully about before dismissing. And really take, this is a very, very significant illness. And the role, I think, of all clinicians is to raise public awareness, because if patients are aware, they will get themselves past a receptionist with just a vague rash or a few summer flu symptoms. They'll know themselves what the risks are. And clinicians, early diagnosis, early treatment, read code properly so that we get some idea of what's going on nationwide, and think about the possibility of late Lyme and be aware of the scientific uncertainties and support your patients. And I'm going to now hand back to Arlene.
Okay, thank you, Anne. So that was indeed a whistle-stop tour, wasn't it? And we're aware there's a lot of information on the slides, but it's deliberate so that you can go back and look at particular slides or particular information later. So we're trying to create the overall picture for you today. We've got lots of resources ready. We have one called What Health Professionals Need to Know. It's a short booklet. You can download it, or you can actually request a paper copy for you and your team, if that'd be helpful. And we summarise everything we've talked about today into that short booklet. We also want to make you aware of the RCGP Lyme disease toolkit. It's presented as 3 sets of nubs, which is an unusual phrase, but it means new learning bits and new bits that you can summarise into bullet points, really. So it gives you bits on diagnosis, on treatment, etc. And that can be found through the RCGP site, but you can also get to it through our website. We've got a health professional page there that you can get all of these resources on. Can I just check, am I still sharing the slides? If I move to the last slide, are you seeing a picture of a girl in a Westie on this one? And I think you need to move the slide for me then, please. Thank you.
We are all in seeing that, yeah.
Yes, thank you. So we started with quite a sad story about where it all went wrong and where poor knowledge leads to poor outcomes. This is a story that will encourage you, I think, to know why it matters to know all about ticks, tick bite prevention and Lyme disease, how to treat it effectively. This was Olivia. She used to be very keen on hill walking and did quite a few of the Scottish Munros, and she was very well aware of the need to do tick checks at the end of any outdoors trips. But one day, having removed lots and lots of ticks from her wee Westie dog, she herself found this engorged tick in her bed. Now, the dog did come in and out the bed, so the first assumption was it was from the dog, but it was quite engorged, so it's a bit horrible to look at, but she got rid of it. Then about 10 days later, this red circular rash appeared on her leg, on her lower calf. Now, she didn't remember ever being bitten by a tick or having an engorged tick or anything attached to her there. And it was a strange one because it was just a kind of red circle, it wasn't a bullseye, and it was a bit itchy in the middle. And she thought, wonder if it's a horsefly bite, because there were horseflies around where she was. And then the next week, just to complicate things, she had gone at that time for her very first COVID vaccine. So you can place exactly where we were in time. It was about those 5-6 years ago. And at that stage, she developed these flu symptoms, which of course looked like a reaction to the vaccine. But about 5-6 days later, she still felt really unwell and fluey. And so at that point, she went for a Lyme disease test and it came back negative. Well, it was after that that the penny dropped, that actually this was a combination of symptoms. It was finding an engorged tick, the rash that had appeared on the leg, and then the fluey symptoms. It was Lyme disease. And so she went on advice to see her GP right away, who recognised she needed treatment and gave her 3 weeks of doxycycline, which was appropriate. And she did continue to take that for the 3 weeks, but she still had quite a lot of the symptoms by then. The fatigue was really bad. She had a bit of brain fog, which meant she was mixing up her words. She had some of these neurological symptoms too, and she knew she still wasn't well. So she went back to the GP at that point and said, I'm still suffering and I believe that I can, it might be appropriate to give me a second course of antibiotics. And of course he did that, and he gave her amoxicillin 500 milligrams 3 times a day. And at that point, she was talking to me about it, and we recognised this is under treatment. So I sent her back to her GP with the information from the NICE Guideline and from the toolkit to say this is under treatment and it needs 1 gram 3 times a day. And at that point, the GP very graciously put his hands up and said, oh, I just need to know what to do here because I clearly am not familiar with this. So he issued her with a new prescription for amoxicillin 1 gram 3 times a day for 3 weeks. As Anne said, high doses, long periods of treatment. And she took that course of treatment. And the symptoms then disappeared, but I would have to say the full recovery took her a few months after that, she would tell you. But the important thing is the jigsaw was put together, and you'll see from that it wasn't that easy to just see it at first sight, but with the right treatment and the right response, it had a very different outcome, and she was fully well after a matter of months and having the right treatment. So I hope that that will encourage you that there's a reason why early recognition, early treatment, appropriate treatment really matters. And you as healthcare professionals have a really important role to play in this. And that's before even thinking about the patients Anne talked about who've had these symptoms for a long time and they've been undiagnosed. So if we talk about what do you do with this, can we encourage you to develop a Lyme aware team? And if you're going to do that, then what we would encourage you to think about is sharing what you've learned today with your team. Think about pointing them to the Lyme disease toolkit on the RCGP site. There's also an e-learning on that, which is very good. It's free to all healthcare professionals. It only takes about 30 minutes, but it's a summary of what we've talked about today. If you're in primary care, you may want to think about making this a quality improvement activity for your practice. If you're in community pharmacy, then there's extra learning through CPPE that we've actually helped to write on recognising EM rashes. How do you differentiate between them and infected insect bites? May every year is Global Lyme Awareness Month, and so there's lots of activity happens then. Buildings will be lit up green. You may have seen some of them. Maybe there's some in your area that you could encourage to light up green. Just to start asking that question, what is green about? What is Lyme disease about? Who needs to know? We all need to know. And we've got lots of information, as do some of these other sources as well. We would love to make these resources available to you and your teams. We've got posters and leaflets, all sorts that you can download from the website, or you can request them from the charity to send you out the posters to put up in your practice and the leaflets to have. And then we would ask you on a very personal level, would you like to help the charity? Would you like to help Lyme Resource Centre in getting the word out to friends, to families, to those that you work with? There's lots of ways we could do that together. If you have heard today about this and think, I would really like to help the charity do this, we would love your help. We would really love that. There's different avenues for doing that. We have outdoor events where it's very focused on the public. We have others which are health professional events like this today. Maybe you're someone who runs marathons or cycles or likes a challenge. Would you like to fundraise for us to help us to keep doing what we're doing and to spread this information and knowledge a bit wider? Or to simply donate to us? We're always looking for any donations that you might like to give, because we're all volunteers at the moment in the charity. Everybody gives of their time freely. Most of us, our families or ourselves, have been touched by Lyme disease, and that's the motivation. But obviously the resources take a bit of money to do that. And if you would like to volunteer for us, we've got a whole volunteer pack ready too. So that's just a wee plea, because I know there'll be some of you out there who will actually think, oh, I was going to run that 10K and wondered who to do it for. And just as a final slide really is just to say to you again, the awareness materials are all on our website. You can find them there. And just a final plea to keep Lyme disease on your radar. We would say to you, when you're seeing patients, when you're with families and friends, think about Lyme disease. Could it be Lyme disease? And I hope today what we've done is we've taken you through a topic that's maybe a bit more unusual. People say it's a rare disease. Is it? Or is it just rarely talked about and rarely recognised? But we hope we've brought it to you and given you a different perspective on things. So thank you very much for listening. We'd be very happy to try and take your questions at this point. And we're happy to maybe stop sharing the slides and see what we can do to help answer your questions.
Well, Arlene and Anne, thank you very much. That was incredibly informative. And there's a couple of questions. Soraya Campbell's asked, do multiple rashes mean multiple bites?
Shall I answer that? Not necessarily. The multiple rashes in those images were probably if the infection starts to disseminate, it may well cause further rashes. So you might get multiple small. Obviously, if you had a couple of different tick bites that were all infected, you may well get more rashes at the same time-ish. But this might be spreading over weeks or months even. Sometimes people's EM rashes last months and months and months and months. But yeah, probably it's disseminating into the skin. And often if you biopsied the edges of those, you would find that you would actually find the bacteria in the rash.
Thank you. And how common is Lyme carditis?
I think we don't know that because how often do people look for it? I think they suggested something like 10%. But you may want to be thinking about it in young people, arrhythmia, where they should have no other cause. It can even be in children. There were several fatalities even in young people in the States have been recorded, and that actually occurred not long after the tick bite itself. Again, testing may not always be reliable, but it can be very serious. And sometimes it could be non-specific. Could be pericarditis, could be myocarditis, could just be a general cardiac symptoms. There is also a story on our website of a very eminent doctor in the States who ended up needing a heart transplant because of the 10-year or more delay in diagnosing his Lyme carditis.
Wow. In terms of the video kind of showed how maybe the public should remove a tick correctly. Once they've done that, is there anything else they should do in terms of treating that area? And should they see a GP automatically or wait for symptoms? What is the situation after successful removal of a tick?
So theoretically, if you could clean the wound there and then with an alcohol swipe or anything, that would be great. But if you're outdoors, that may not happen. I think if you found one tick, then definitely check properly for more, especially in children, around the hairline and any sort of other areas on the skin. And then it's really a case of just watching. There's no point seeing the GP at that point. A test is not going to show anything. It's a scary thing because people think, well, maybe it'd be safer if I just have the antibiotics. But 3 weeks of high dose antibiotics without good reason is difficult. There has been some research suggesting that 1 or 2 doses of doxycycline immediately could prevent Lyme. But the issue there is that research only involved following up on it was done in the States. It was a group of patients followed, I think, for about 6 weeks, and the outcome was whether or not they developed an EM rash. What we don't know is whether that antibiotic stopped somebody getting an EM rash and whether they then developed any symptoms later because the research was not continued. So that is another area where maybe people do need to be researching.
Right, and Julie Dixon asks, is there any particular time of year where the likelihood is greater of getting a tick bite? Are they active all year? Are they seasonal?
That's a good question to ask. I mean, it used to be the tick season was considered to be March through to about September. What we're finding now is people are seeing ticks almost all the year round, but certainly much earlier in the year. February can be quite common and going on later. And of course, one of the reasons for that is climate change is definitely affecting the tick populations. There's been a very interesting study done in Stirling University by a mathematician actually a couple of years ago, and it showed that for every 1 degree that the temperature rose, the tick population would be projected to grow by 6 times. So that tells you that actually the temperature changing does have a massive effect on the numbers of ticks. The other thing that's very commonly known is that there are hotspots for ticks. You know, everybody knows the Scottish Highlands is the worst. It certainly is. But also the West Country down in you know, Devon, Cornwall area, East Anglia is a hotspot. The New Forest is a hotspot. But if you remember the map that Anne showed, ticks have been reported everywhere now. Sightings of ticks have been reported everywhere. The incidence of the bacteria they carry may vary in different areas, but certainly the tick populations are growing and they're everywhere.
Right.
I actually saw a couple of cases, and 2 years ago, I think, when we had a very warm autumn, I was seeing EM rashes at the end of October going into November. People who'd been bitten in that October holiday. So any time of year is possible.
And there's a question, if you happen to be out and about and have a tick lodged in, you don't have a tick removal tool, any suggestions?
Yeah, that's tricky, isn't it? I mean, the first thing we have to say is please carry one. You know, we're encouraging everybody. We have tick removers that we give away now to some of our Duke of Edinburgh participants and some of the kids, so that they've each got one in their pocket. Now, if you don't have one, what you could do is, if you've got a credit card and the ability to cut a little hole in it, you know, that would get under the tick, because this is the key thing. What you don't want to do is to squeeze the body of the tick, because that then the regurgitation into our body means that you're at higher risk of any infection transferring. So that's why a tick remover tool tries to lift it out from underneath the body of the tick. If you don't have something with you, I mean, people have used their fingernail. That's risky. They've used things like, you know, burning the tick or putting alcohol on it. We really would suggest you don't do that, because anything that can encourage that tick to regurgitate into your body is just going to increase the risk of infection. And have you any other suggestions of what people can do with
another possibility is a thread. If you were able, a thread for something, obviously not a piece of string, that would be too much, but maybe a thread from a piece of fabric that you could just hook underneath it. I think if all else fails, you may well have to use your fingernails or somebody else's if they're long, because you don't want to leave it there. So it is important to try and move it. But it may be, if you haven't got a tick remover, have a look on the website that we can, as to how to get one. And if it came to it and you were on a trip and you didn't, then cut, as Arlene said, cutting a slit in piece of card or an old credit card or something to carry around.
Okay. Well, listen, that's the end of the questions at this moment in time. Thank you very much, and just to let everybody know that this will all be available to download within about a week's time from the NOLEX website. I think, Arlene, you'll be using it at the Resource Centre website as well, I think.
Yes, yes, indeed.
And again, thank you very much, everybody, for attending. And thank you again, Anne and Arlene. That was terrific. Cheers.
Thank you. And please contact us if you have any questions. Yes. We're very happy to help.
Yes.
Thank you.
We can do learning for small groups or short pieces of learning or provide that, please tell people just to get in touch. admin@lymeresourcecentre.com. Thank you.
Thank you very much. Bye-bye.
Thank you for having us.